Welcome to this educational resource for pain healthcare professionals who manage spinal pain. As you know, spinal pain is a prevalent condition that can drastically affect an individual's quality of life. Over recent decades, we've made tremendous strides in its treatment. C-arm guided procedures have emerged as a leading intervention, particularly for adults experiencing chronic, moderate to severe spinal pain. In this video, we'll delve deeper into the intricacies of these innovative strategies, aiming to further our collective knowledge and enhance patient care. Spinal interventions involve using diagnostic or therapeutic techniques to alleviate and manage spinal pain. These procedures are usually performed under the guidance of imaging technologies such as fluoroscopy to ensure precision and safety. The C-arm fluoroscopy guided procedure has several advantages. It provides real-time visualization of the bony anatomy and needle, making it an accurate strategy for spinal intervention. Join our masterclass membership today and unlock a treasure trove of knowledge. Benefit from twice-weekly lectures, clinical case discussions, and image interpretation insights. Elevate your skills and connect with like-minded doctors. Subscribe now for a brighter professional future. Ultrasound-guided procedures for treating spinal pain have been gaining traction for nearly 2 decades. These methods relieve various conditions, including cervical radicular pain, cervical and lumbar facet joint pain, cervicogenic headaches, iliolumbar ligament pain, and sacroiliac joint pain. I do not deal with the ultrasound-guided procedures in this video but focus on the C-arm guided procedure. Before we dive into the video demonstrations, reviewing the fundamental knowledge surrounding spinal pain is necessary. It includes understanding the classification of spinal pain and exploring the various interventional treatment options for each type of pain generator. First, let's clarify spinal pain classification into 2 main types: somatic and radicular pain. Somatic pain is typically localized, originating from structures like the facet joint, ligaments, posterior torn annulus, and at times from end plate fractures or subchondral bone marrow edema, which is often indicated by modic type 1 changes. In contrast, radicular pain manifests due to nerve root compression or chemical irritation. In addition, this type of pain commonly arises from conditions such as a herniated nucleus pulposus or spinal stenosis. We'll examine the treatments best suited for these distinct pain classifications as we progress. To manage these different types of pain, several interventional procedures are employed. For somatic pain, techniques such as medial branch block or facet joint injection, intradiscal injection, and sacroiliac joint injection are often used. Each of these procedures involves targeting the specific area of pain or inflammation with therapeutic agents, aiding in pain relief and recovery. In cases of radicular pain, interventional procedures such as transferaminal injection and interlamina injection are commonly utilized. These treatments are directed at the nerve roots, aiming to alleviate the pain associated with nerve root irritation or impingement. As an operator, personal protective equipment is crucial during these procedures due to the ionizing radiation involved. It includes wearing a lead apron, lead gloves, and lead glasses. These are designed to protect the operator from radiation exposure. Finally, the maintenance of aseptic techniques is paramount to prevent infection. Operators should ensure the preparation of aseptic cloths and dressings. The surface of the surgical site should be cleaned meticulously and then dressed to maintain sterility throughout the procedure. Interlamina injection in the cervical and lumbar spine. An interlamina injection is a common interventional procedure to alleviate cervical and lumbar spine pain, either radicular or discogenic somatic pain. Also, it covers a broad range of spinal pain because it spreads the steroid and local anesthetics into the wide area of epidural space broadly. Conventionally, most interventionists use an AP view and lateral C-arm view to guide the needle. But I discovered that the oblique contralateral view provides a more precise, delicate anatomy of the bony structure and contributes great time saving, which can decrease the radiation exposure to the patient and doctor. I will begin with the cervical interlamina injection. I will show you a cervical interlamina epidural injection via the right C7T1 parasagittal approach with the help of a contralateral oblique image. First, adjust the C-arm to target the cervical vertebra level on an AP view. During the AP view, ensure the C-arm is perpendicular to the spine, not the patient's body. You'll generally need a cranial tilting angulation of the C-arm, which can depend on the cervical posture, but typically requires a 3 to 5 degree cranial tilt for the C7T1 approach. In this procedure, I typically utilize a 23-gauge 2E epidural needle. I use long placenta forceps, which can be beneficial in reducing radiation exposure to my hand, but they require some practice to handle effectively. The needle is directed toward the inferior border of the interlamina space at a parasagittal area, rather than the middle or interlamina space, due to safety considerations. I personally favor the parasagittal epidural approach, which provides added benefits for treating unilateral foraminal, subarticular stenosis, and paracentral or lateral types of HCD. At this point, I'll need a contralateral oblique view. Upon rotation, the compass indicates about 60 degrees. As I observe the lateral profile view of multiple cervical laminae, I draw an imaginary line connecting the innermost aspects of the laminae. The needle is directed toward the central aspect of the interlamina space. As the needle nears the posterior dural line, it's crucial to be wary of accidental penetration into the dural space. I hold the needle with my left hand, which functions as a stopper for the needle. Next, I connect the syringe, which contains contrast media. The mini-volume connection line is beneficial as it helps minimize exposure to scattered radiation and reduces the risk of accidental needle movement when connecting the syringe after ensuring correct needle tip placement. The correct epidural space placement is indicated by the vertical linear spread of the contrast media. Following this, I confirm the contrast spread in the AP view. I then recheck the contrast spread in the contralateral oblique view. Finally, I connect the syringe containing the steroid mixture. My preference is for 2 ampoules of dexamethasone palmitate, each containing 7 mg of dexamethasone. The next demonstration is on the technique for a lumbar interlamina epidural injection, utilizing AP and contralateral oblique C-arm image guidance. Many doctors tend to insert the needle under AP image guidance and verify the final needle position using a lateral C-arm view. Recently, I have seen more experts appreciate the advantages of a contralateral oblique image, a technique I introduced on my YouTube channel. For this procedure, the needle will move from my side to the opposite side. I will tilt the C-arm caudally to expand the interlamina space of L45. My needle will puncture the skin in the lower part of the left paracentral interlamina space and move upward. The depth to which I insert the needle on the AP view is based on the patient's body mass and the sensation in my fingertips. After this, I rotate the C-arm to the contralateral side. The C-arm is rotated as much as possible, until a clear profile of the lamina's cut section is visible. Once the clear profile of the cut section of the laminae is found, the needle is advanced until it overpasses the yellow line. The yellow line corresponds to the thickness of the ligamentum flavum. Estimating the thickness of the ligamentum flavum from an MRI scan before the procedure can help in approximating the thickness of the yellow line. When passing the yellow line, it's important to hold the needle with fingers from the opposite hand to slow the advancement of the needle. A correct needle placement will yield an elongated contrast pattern. To illustrate further, let's refer to a schematic drawing of the correlated image. In this crowded area, the lamina and pedicle are located. If the approach is from the left side, a right oblique image is used. The yellow circle represents the left pedicles, while the red circles mark the profile of the cut section of the laminae. The green line connects the internal aspects of neighboring laminae. Similarly, if the approach is from the right side, a left oblique image is used. The red circles again mark the profile of the cut section of the laminae, and the green line connects the internal aspects of the neighboring laminae. In addition to providing a faster and clearer image, the contralateral oblique image offers another advantage: consistency. The illustration showing a lateral C-arm and an axial lumbar sectional image highlights this point. If a central epidural route is chosen, it may appear that the needle did not reach the posterior epidural space. However, if a paracentral epidural route is chosen, it might look like the needle has overshot the posterior epidural space. Contrast media can confirm the posterior epidural space, the medial branch of the lumbar spine. Medial branch blocks are a common interventional procedure for managing facet joint pain, including in the lumbar spine. They involve injecting local anesthetics near the medial branch nerves that supply the facet joints. The C-arm guided lumbar medial branch block procedure for both sides at the L3, L4, and L5 levels using needles without a stylet involves: position the C-arm fluoroscope over the lumbar spine, and obtain anteroposterior and oblique views to visualize the target levels with optimal cranial or caudal tilt depending on the deformity. Target: the target location is typically at the junction of the lateral aspect of the superior articular process and the root of the transverse process. This junction may coincide with the waist of the Scotty dog appearance in the oblique view, but the waist is the pedicle, not the junction. So try to find the cortical margin of the transverse process and the lateral aspect of the articular process. Needle insertion: under C-arm guidance, insert a 26-gauge, 9 cm long needle without a stylet. I do not anesthetize the skin because it wastes time without benefits. Adjust the C-arm as needed to visualize the target medial branch locations in the oblique view. Needle advancement: advance each needle toward the target medial branches until you touch the bone using long forceps, such as placenta forceps, to protect your hands. Needle positioning: once the needles are in place, reposition the C-arm into the AP view to verify that the needles are in the correct locations for the medial branches of L3, L4, and L5 on both sides. Contrast injection: inject a small amount of contrast dye through each needle to confirm proper placement and ensure that there is no intravascular uptake. Anesthetic and steroid injection: after confirming proper needle placement, inject a mixture of local anesthetic and a steroid through each needle to block the medial branches and provide pain relief. I prefer bupivacaine and triamcinolone. The sacroiliac joint injection. Sacroiliac joint injections are used as a treatment for pain originating from the SI joints. These injections usually contain a corticosteroid to relieve inflammation and pain relief. The procedure is typically performed under fluoroscopic guidance to ensure precise placement of the medication. But it can be replaced by the ultrasound-guided procedure. The next demonstration will present the inferior recess approach to sacroiliac joint injection. Although the sacroiliac joint, SIJ, is large, its complex nature and individual anatomical variations can make it difficult to access. However, in my clinical practice, I've noticed that the inferior recess approach has the highest success rate when compared to targeting the lower one-third or other approaches in sacroiliac intra-articular injection techniques. A popular technique involves targeting the lower one-third of the bony sacroiliac joint. This method may appear straightforward, but there are several disadvantages. For instance, the clear, double line of the joint often seen on scans is usually deceptive. Thus, you typically first make contact with the bone, then move the needle around for some time. You need to maneuver the needle in various directions until you feel it enter the joint, requiring anesthetization of the area before the procedure. Furthermore, intra-articular injections can be time-consuming, with the mean fluoroscopy time reported to be approximately 1.56 minutes. There's also a high risk of contrast contamination or technical failure. Before I share the case studies, let me explain the inferior recess of the sacroiliac joint. It is a synovial outpouching from the distal margin of the bony sacroiliac joint. The iliac bone typically covers the sacral bone at the inferior tip of the joint. However, several variations of the inferior tip of the bony sacroiliac joint exist. A schematic drawing illustrates the variations in the inferior aspect of the bony sacroiliac joint. In the diagram, the iliac bone is represented by a yellow plate, and the sacral bone is represented by a blue plate. The alignment of the joint line can be in inferior lateral oblique, vertical, or inferior medial oblique directions. The procedure is simplified if the iliac side is shorter than the sacral side, as it allows for a wider opening of the inferior joint space. However, when the iliac side is longer than the sacral side, it can pose a challenge. Any bone spur on the sacral or iliac side can block the gateway. Thus, observing the bony anatomy before introducing the needle is recommended. Another tip for a successful sacroiliac joint injection involves careful fluoroscopic observation. Even if the needle tip appears in the side on fluoroscopy, the contrast dye spread might not confirm this. Once the contrast dye is injected, fluoroscopic landmarks can be obscured. Therefore, it's crucial to ensure correct placement. After the needle tip is properly positioned, its placement is confirmed under continuous fluoroscopy, moving the C-arm in right and left oblique directions. On dynamic fluoroscopy, the needle tip should stay within the joint line and not appear outside of it. If the needle tip seems to be on the bone, outside of the joint line, it is not correctly placed. The lumbar intradiscal injection. Intradiscal steroid and botulinum toxin injection is an emerging treatment approach for managing chronic discogenic lumbar pain, particularly when associated with posterior annular tear and subchondral bone marrow edema characterized by modic type 1 changes. Next, I'll demonstrate a more complex case involving an intradiscal injection via the right L3-4 Cambens triangle and an L3-4 facet joint injection, using 50 units of Botox with triamcinolone. This is intended to alleviate pain originating from the L3-4 subchondral bone marrow and the L3-4 subarticular stenosis. The pain diagram of the patient suggests that the discomfort in the buttock arises from the discovertebral complex. Though this isn't an official term, I've coined it for clarity. I'll elaborate on the concept of adult discovertebral complex pain later. The technician has already adjusted the C-arm with a caudal tilt of 5 degrees and a right ipsilateral oblique tilt of 30 degrees. Bony sclerosis is observed in the lower subchondral bone of L3 and the upper subchondral bone of L4, accompanied by disc space narrowing. The compass indicates a 30-degree rotation. I'll initiate the procedure by puncturing the skin at the right Camben triangle. If there's a high risk of nerve root injury due to a severely narrowed ipsilateral foraminal space, I could approach from the opposite side. I request an AP view next. Then, I'll proceed slowly and meticulously to avoid harming the nerve root. In the past, I confirmed the intradiscal space with contrast media. However, to prevent an increase in intradiscal pressure, I now only inject a minimal volume of medicine. This is because an intradiscal injection risks pushing the internal content to extrude through an annular defect, and even a small volume of contrast can add to the rise of intradiscal pressure. In cases of severe foraminal stenosis, I often substitute a transferaminal injection with a facet joint injection. This reduces the chance of post-injection soreness or radicular pain associated with an intensive transferaminal approach. There are several advantages to facet joint injections in such cases: reduced chance of post-injection radicular pain, longer steroid retention in the target, and a larger reservoir of medicine in the foraminal space. I prefer the inferior recess approach to the facet joint as it has certain advantages over the superior recess approach. To successfully access the inferior recess, you need to focus on the inferior margin of the L3's inferior articular process over the L4 body. It may appear easy, but it can be challenging for beginners, so proper practice and observation of the inferior recess is recommended. I'll show an ipsilateral oblique image with the infiltrating contrast media. If the joint capsule is intact, you'll feel resistance in your syringe after injecting 1 cc of medicine. Ignoring this resistance during fluid delivery can cause nerve root compressive pain in the patient. Transferaminal epidural steroid injection in the thoracic and lumbar spine. Transferaminal epidural steroid injections are frequently used to alleviate radicular pain, which radiates along the nerve caused by irritation or inflammation at the nerve root level. In the next demonstration, I will illustrate the left L5 and S1 nerve root block technique using ipsilateral oblique (AP) and contralateral oblique C-arm image guidance. Initially, I'll introduce the needle guided by the ipsilateral oblique image. Following this, I'll rotate the C-arm to the AP view. These two different angles of stereo views allow me to estimate the needle's depth and position. For double confirmation, I'll turn the C-arm to the contralateral oblique position. I'll rotate the C-arm to the maximum extent possible to visualize a clear profile of the pedicle's cut section. Remember to keep in mind the pedicle's location and the nerve root pathway in the left contralateral oblique image. Notice the filling defect of the L4 nerve root as it passes along the pedicle's medial border. Consequently, the nerve root will pass beneath the pedicle. On the AP view, this triangle seems like a safe triangle. I will proceed with advancing the needle while under contralateral oblique image guidance. Please monitor the needle tip. Following this, I will revert to the AP view. If positioned correctly, the needle tip should reside within the safe triangle. When the needle is placed correctly, the contrast will spread to the transferaminal and epidural space. Please keep this image in mind when reviewing the contralateral oblique image. Next, I'll transition to the S1 nerve root block. I'll rotate the C-arm cranially and mildly ipsilaterally. The most efficient way to identify the posterior foramen of S1 is to locate the pedicle of S1 and the radiolucent hole adjacent to the pedicle's inferior and medial borders, and then rotate the C-arm to a contralateral oblique position. Identify the pedicle and the yellow line below the pedicle of S1. It appears straightforward, doesn't it? I will be discussing an episode of another thoracic transferaminal epidural steroid injection technique. We will be focusing on bilateral T8 transferaminal injections. This procedure can be more challenging than lumbar or cervical transferaminal injections for several reasons. First, there is anatomical complexity. The thoracic spine has a more complex anatomy than the lumbar and cervical regions, with ribs and their articulations, narrower intervertebral foramina, and a smaller spinal canal. These factors can make it difficult to target the desired foraminal space and nerve root accurately. Second, there is limited working space. The smaller size of the thoracic foramina and the proximity of adjacent structures can limit the working space for the needle, making it more challenging to safely and accurately position the needle tip. Third, there are neighboring vital structures such as the pleura and lung. The proximity of these structures to the thoracic spine increases the risk of pleural puncture or pneumothorax during the injection. To determine the target level, I asked the patient to mark the painful area and then trace along the rib when there is paraspinal or lateral chest pain. To begin, I use the AP view and count up from T12 to locate the correct thoracic level if I previously informed the level by the imaging studies or other clinical information. There are no specific landmarks in the middle of the thoracic spine, so starting from T12 is necessary. Next, I will count up from the T12, T11, T10, T9, and T8 and then put the long forceps to the target level under C-arm guidance and undergo the procedure. Once I have identified the target level, I tilt the C-arm to find the endplate line of that level. Usually, I tilt the C-arm in the upper thoracic spine cranially and lower thoracic spine caudally to align the endplate. The tilting angulation degree depends on the deformity of the patients, as many patients show multiple compression fractures and deformities in the older age group. And then, I turn the C-arm to the ipsilateral oblique image. Next, I am looking for a clear window for the intervertebral space. Typically, there is a window between the inferior lamina of the upper level and the ribs of the lower level in the oblique image. Unfortunately, the window is not as clear as in previous patients. The C-arm image shows more disc height loss, marginal sclerosis, and a narrower, blurred window. After finding a window, I advance the needle toward the center of the window just above the upper medial border of the rib. I measure the length of needle advancement and feel for the intertransverse ligament during the advancement. Once the needle reaches the transferaminal space, I turn the C-arm to the AP view and the contralateral oblique image. I can precisely determine the needle depth required to reach the foraminal space using the AP and then the contralateral oblique images. For the left transferaminal injection route, I aim for the 6 o'clock position under the pedicle as my final needle destination in a contralateral oblique image. Once the needle is positioned, I administer contrast media to visualize the transferaminal and epidural spaces. I carefully observe for vascular uptake and adjust the needle position to avoid intravascular injection of steroids. The intercostal spread of contrast media proceeds first, then opacifies the intervertebral and epidural space. I don't see vascular uptake and good contrast spread into the epidural space, so I will administer the steroid mixture. I will check the contrast spread during the injection process to ensure it fills the proper space. Next, I proceed with the right T8 transferaminal approach, using the same technique and finding the space between the inferior lateral border of the lamina and the upper border of the medial end of the rib. In most cases, you cannot see the clear pedicle and lamina in the thoracic spine compared to the lumbar or cervical spine. However, the contralateral oblique image shows a clearer view of the pedicle and a tangential view of the lamina, which helps determine the proper needle depth. At this point, I administer the contrast media under the contralateral oblique image and observe good contrast spread to the lower and upper levels of the epidural space without vascular uptake. I also observe the good contrast spread into the transferaminal and epidural spaces on the AP view. Finally, I inject the remaining prepared steroid mixture and complete the procedure. Beyond these procedures, there are more advanced interventions for severe or refractory cases. These include endoscopic discectomy and foraminotomy, which are more invasive and typically require hospitalization. Endoscopic discectomy involves removing part or all of a herniated disc through an endoscope, whereas foraminotomy entails enlarging the foramen to relieve pressure on a compressed nerve root. Both procedures are often performed under fluoroscopic guidance to ensure precision and safety. In recent years, a technique known as pulsed radiofrequency treatment has emerged as a promising approach to managing both somatic and radicular spinal pain. This involves sending pulsed electrical signals to the targeted nerves or tissues, providing pain relief without the need for hospital admission. Thank you all for joining today. We've explored various facets of C-arm guided procedures, showcasing a range of techniques that might be adopted based on individual characteristics and personal interventional experiences. It's my sincere hope that these demonstrations have served as a valuable resource, helping to illuminate the fundamental concepts of spinal intervention under C-arm guidance. Thank you once again for watching.